Good evening, everyone. Thank you for taking time out of your busy schedules to hear a discussion tonight on pediatric sports injuries, specifically anterior cruciate ligament or ACL injuries. Let's get started with some introductions. So my name is James Barsi. I'll be the moderator tonight. I'm a pediatric orthopedic surgeon here at Stony Brook Children's. I'm joined tonight by three experts, so Dr. David Wallach, Dr. Diana Patterson, and Dr. Kristin Hopkins. I'm going to have them introduce themselves to our viewers tonight. So let's get started with you, Dr. Wallach.
Hi. So obviously I'm Dave Wallach. I'm a pediatric orthopedist. We take care of a myriad of many medical problems, including sports injury in children. And that's one of the reasons I was asked to join tonight. And thank you for having me.
Great. And then Dr. Diana Patterson.
Hi, so I'm, like you said, Diana Patterson. I'm a sports medicine trained orthopedic surgeon, taking care of a crossover of all those myriad of injuries that Dr. Wallach mentioned in sort of all ages as well. And again, thanks for asking me to be here tonight.
Great. And then Dr. Kristin Hopkins.
Hi, I'm Kristin Hopkins. Similar to Dr. Patterson, I'm also sports medicine trained. Seeing a lot of our young athletes, both, school age and our weekend warriors that extend more into the adult population, but I'm happy to see any and all sports injuries.
So thank you everyone for the introductions. I think our viewers are in for a great discussion tonight on ACL injuries. We're going to go over why the child's knee is different than the adult, how the ACL is injured, and more importantly, how it's treated. And we're going to go over some prevention strategies as well. I'm going to ask all of our viewers that if they have any questions, to please type them in the comment box, and we'll do our best to try to answer them. So if our panelists are ready, let's get started. So our first question is going to be to you, David Wallach. So in order to understand how to avoid and treat pediatric knee injuries, our viewers really want to know, what are the ways in which a child's knee is different than an adult knee?
Thanks. So the fundamental difference between an adult and a child is growth plates. It's the potential for growth. The growth is there because of these cartilage connections that are present in the thigh bone, the femur, and the tibia, which is the shin bone. And because of those growth issues, that's something that needs to be respected when we treat them so that we do not alter the growth of the child. The other thing we need to think about is ligamentous laxity. As you know from your own experience, as you age, you get a little stiffer. Well, children are as flexible as they're going to be. And as such, they have much more excursion to their knee. So when we examine them, we need to compare side to side. And perhaps the last thing we have to think about is their maturity in terms of how they behave. Impulse control, will they listen to instructions? How eager are they to return to the field? These are important issues. Certainly at all age groups, there are people who lack impulse control. But it's very common, more common in the immature brain to do things that maybe they shouldn't really be doing.
Great. So if I'm hearing you correctly, the thing that really separates kids from adults is the presence of a growth plate. So what can happen if we fix a child like an adult?
So if your technique, and now we're talking operative here, if your technique causes an injury to a growth plate, you may cause it to prematurely close. And this may result in either a short limb or perhaps an angled limb. And this is not desirable. If you make the knee stable, but it's too short or it's not straight, they're certainly not going to be happy and it won't have appropriate function. So our techniques have to be appropriate for age and growth remaining. And there are ways that we work so that we can respect the growth plate. ACL injuries can happen in 8-year-olds and 9-year-olds. Certainly not as common as the teenager, but they do happen in little children. And if you were to treat them with the same techniques that you use for an adult, which do cross the growth plate and are more apt to cause injury, you will cause a more significant problem with how the limb grows. So we select different techniques that will give the stability that we seek and minimize the potential of altering growth.
So good answer. It sounds like that for ACL injuries in kids, not only do we have to actually repair or reconstruct the ACL, but we also have to take into effect the amount of growing that they have left. So our next question, I'm going to address this to you, Diana. So what exactly is an ACL injury, and what are some common causes?
So I guess first I'll start with a couple sentences just for those who sort of don't know what the ACL actually is. ACL stands for anterior cruciate ligament. It's one of the two main ligaments inside the knee. The quote collateral ligaments are named as such because they're around the knee. And then so the ACL is one of the main ligaments in the knee, and its main job is in certain positions of the knee, whether that's sort of positions that it's in space. It prevents the tibia, so the leg bone, from moving too far forward on the thigh bone or the femur, and as well as, has a lot of important stability when you're trying to, turn quickly or in different directions and stuff like that. So an ACL injury is either a sprain or a partial tear, or, in those unfortunate cases, a complete rupture of the ACL ligament inside the knee, either in some patients, might be more common in the younger patient, would be sort of an avulsion, as we would say, when it pulls off the bone on either end, more common maybe on the tibia. And then, or you can have, mid-substance, as we say, when it basically is like, unfortunately, a rubber band that just sort of snaps in the middle. And then there's a very, a spectrum of some partial injuries, which can be anything from a sprain or a partial tear. And we're still sort of studying exactly what that can mean for any individual patient of any age, because, there are studies and we look at some who have some partial injuries, partial tears, and seemingly have zero, no symptoms, and some who have some symptoms, and some who still have instability with even just normal walking. So there's definitely a spectrum. The most common, and, why we're all having this conversation tonight, would be a complete rupture of the ACL in the middle of the ligament. And then, some common causes would be, a lot of it occurs as what we would say is a non-contact injury mechanism. So yes, there is always some that get hurt when you get tackled on the sports field, whether that's soccer, football, or anything like that. But a lot of them occur in a non-contact mechanism, which is either, most commonly is someone who's running and slows down or comes to a sharp, like a decrease in speed, or someone changing direction very rapidly in a certain pattern, or even just, I've seen some also that are more of a hyperextension, where the knee just, sort of goes too straight and just also has a rupture at the same time. And those would be sort of the most common. Maybe it's either running or it's landing from some sort of jump, which is what we see in a lot of more of the winter sports. Falling in a certain mechanism. Most commonly, we would see it in what's called knee valgus. So valgus means sort of the knee goes in towards the other knee rather than out towards the foot. So the hip and the knee are on one side, and the knee's going in towards the other knee. Those are all the most common, I guess, activity-related injury sort of mechanisms that we would see. And then that is also mostly when it's, an isolated injury. Unfortunately, as people get older, and as Dr. Wallach said, a little more stiffer, you can sort of tear some ligaments as well with it. And, there's a spectrum of some injury that can also, occur and injure other, structures inside the knee, which sort of go along with it and affect some of our sort of options in clinical decision making.
Good. So, a lot of people want to know if the ACL is really one of the prime ligaments of the knee. What happens if you don't have an ACL? What happens to your knee, and what can that cause?
So, long term, because the ACL is most important, as I sort of would say, in turning motions or cutting or pivoting. So that can be anything from getting out of your car, getting out of a shower or bathtub, turning quickly when you come down some stairs, or turning a corner. Those are some of the everyday life things that some of both pediatric and some of my adult patients also sort of experience some instability with. Biomechanically in a lab, you don't necessarily need an ACL to play video games or walk in a straight line, or do some other life functions, or as I would say, straight line motion, whether that's jogging or running or bicycling. And so, again, this plays into some of the conversations we have with patients based on, what our options are. But the always concern is long-term, that because you have some instability in the joint and around the knee, you're putting inappropriate additional stresses on the other stabilizing structures, as we call them, the secondary stabilizers. Those can be the meniscus or the cartilage. And so, particularly for younger patients with ACL injuries, that leads to concern for instability on and additional pressure on the cartilage, which could lead to sort of early and progressive, arthritis down the road at a much younger age, because the cartilage is seeing too much pressure, and it can cause meniscus injuries if left untreated, because that meniscus becomes the prime stabilizer of the knee, but it's not designed to be that. So it kind of gives out. And some of our studies show that people who haven't had, some treatment for the, ACL might lead to having some additional injuries down the road. And so, the long-term concern is sort of knee preservation and knee stability, let alone the day-to-day functioning of someone who feels instability with all, daily activities.
And when you say instability, what do you mean? What do patients feel when they have an ACL that's torn?
Good question. I guess they described to me a feeling of the knee just sort of buckling like this, sort of not necessarily that it doesn't want to go too straight, but it's just sort of they turn too quickly and it just sort of gives way and it shifts on them, sort of like this. That's usually, what sort of patients say to me. It's both pain, and then after each of those events, they're going to probably have some swelling and additional injury, particularly if it's happened several times. And so it's a feeling that they can't stand on it or plant on it or rely on that leg in either all positions or some positions.
Good. How about another question for Kristin? So how exactly is an ACL injury diagnosed? What are you looking for?
Oh man. So I feel like there are several ways to answer this question. And, from the sideline doctor perspective, I feel like when I'm standing there and I'm watching and I see somebody go down and it looks like their knee just literally buckled out from underneath them, there may be contact. Most of the time there's not contact. And you say, "Oh, I think that was an ACL." And, it seems to be when someone is pivoting, cutting, drop stepping on defense, something like that. But there's just a very characteristic way that an athlete goes down where you suspect ACL. I think we all watch the Super Bowl and we're familiar. But in terms of sideline assessment, as a sideline doctor, how do I diagnose or suspect an ACL injury? The athlete may swell up right away. They may not, but it's pretty common to get a pretty big swollen knee within a few hours. They may have laxity on manual testing. They may have joint line tenderness. But really, when you get them in the office, they're probably still swollen if you're seeing them within an acute window of, a week or so of their injury. They'll have that increased anterior translation. So as you pull on that tibia and you're kind of sitting on their foot, that tibia is going to slide forward more compared to the other knee. And like Dr. Wallach was saying, especially when you're examining kids, you want to make sure you compare it to the other side. That's part of the beauty of orthopedics, is that most of the time you have two and you can compare one to the other. The other thing that we do is something called like a pivot shift test, which tests more for the rotation. But a lot of times in an acute setting, a patient's too painful and they'll guard against you. They're not going to want you to do that. They may also be really tender along the joint line, either medial or lateral. That can be because when the ACL tears, that shin bone slides forward and the two bones bang together. So you actually will have like bone contusions that happen as a side effect of the ACL tear. And they may unfortunately have a meniscus tear that goes along with just the mechanism of injury. But ultimately, in terms of a definitive diagnosis and giving your patient and their family a specific answer, the answer lies with an MRI. So, we get x-rays, but x-rays only show us bones. So the MRI is key to show us soft tissue, such as ligaments, like the ACL, and then also cartilage surfaces and the menisci. So the answer lies in the MRI ultimately.
Good. So we have our first question. So we have Danny from Setauket. So he wants to know, how can you repair an ACL if you can repair it? So why don't we have Dr. Wallach try to address that?
Thank you. So there are different types of ACL tears. The classic mid-substance tear is not very amenable, really not amenable to repair. But there are some situations that are repairable. Those specifically are what we call avulsions, where you pull off the attachment of the tibial connection, the shin bone connection of the ACL. And because it has a bony portion to it, you can get bone-to-bone healing. The ACL does not do very well with a mid-substance tear, but can do well when there's a bony attachment. These avulsion injuries tend to happen in the young, and so I will see far more of these injuries in children, but you can see it in adults too. It's just a little less common. The repair techniques for these leaves you with ultimately an intact ACL. It's fixed either with a suture technique, which is a stitch down to bone, or with screws. I favor the suture technique, but there are situations where the screws do make sense. With the only caveat with repair, in whether you repair it in the substance of the tissue or if you repair it at the ends, is there tends to be an elongation of the ACL. So it didn't just pull off, but also, like taffy, gets a little extra stretch. And so there may be some residual laxity, and this will need to be addressed. So when we do a repair, we often try to sink the ACL a little bit deeper into its host bed to try to take up some of that laxity. Most of the time, I would say the vast majority of ACLs are actually reconstructed. But like I said, there are very small selected cases where there is a place for repair.
Good. We have another question from one of our viewers, Emily. So she wants to know if there's any correlation between ACL injuries as a child and needing a knee replacement later in life. So why don't we have Diana, why don't you try to address this?
Yeah. So I think that there is unfortunately a correlation, but I wouldn't say that it's necessarily a direct connection. We have a lot of studies out there available for 10 and 20-year outcomes of an ACL injury. And we do know that there is potentially a higher rate of people needing knee replacements in their lifetime, or having arthritis that might lead someone to want to get a knee replacement at some point. But we have not yet figured out exactly whether there's a set time, because there's also a large group of patients that do completely fine. I have some patients in my office who have had, IAC, they've had an ACL 20 years ago with even older techniques than we have now. And I expect that they're going to have terrible looking arthritis and totally pristine looking knees, and they've been completely fine. And then some who have had, I meant to say treated non-operatively, not had surgery, 20 years ago and been very active and been fine. And other people who seem to get arthritis, more rapidly. And I think, studies we're still figuring out exactly, things that might happen to the microenvironment of the knee and bad injury, whether that's the swelling in that Dr. Hopkins mentioned, or, some of maybe injury to the cartilage that, we can't see with the naked eye yet. And so there's, lots of people in labs who try to study that to try and figure it out. And the other thing that we also have learned thus far with various studies that we've done is that patients who have, as we would call it, ACL deficiency, so that means someone who doesn't have an ACL, even if they don't have, they might, instability symptoms, they might develop an X-ray that looks like they might need a knee replacement. These are one of the things we still are an unknown in orthopedic surgery, because they develop an X-ray that might look terrible or might look like they have, bad arthritis, but completely asymptomatic and doing very well. And, I don't usually recommend knee replacement to someone like that. So I guess circling back to the primary answer, I would say, yes, unfortunately, there is a correlation, particularly I think more and more we learn in kids who have a very young age who have maybe an ACL injury, because it's just a greater time period that they might be without an ACL. But I don't think it's necessarily like a sign on the dotted line, you're going to have a knee replacement in X years.
Good. We have another question from Carly. So she wants to know, what are about the long-term effects of an ACL injury? Does a childhood injury like this guarantee issues or limitations as an adult? And I'm going to have Dr. Hopkins address this one.
So, good question, Carly. I do think it is a little bit related to the question that Diana just answered too. And I think that unfortunately, any knee that's had a trauma, it predisposes you to earlier development of arthritis. That's kind of like the blanket statement that we use. But I do think this is an area where there's a significant difference between our teenage population and the adults that I see. So, if I have a 15, 16, 17-year-old kid who maybe isn't even wanting to play college sports or doesn't even want to continue out their high school career, we're still telling them that they need to have their ACL reconstructed, because it's already been shown that without that stabilizer to the knee, every instability episode that they have is causing more trauma to that cartilage and putting that meniscus at risk. So, the conversation I have with a 17-year-old, you say, you need an ACL reconstruction because you need to be able to trust this knee, and we need to restore the stability of this knee just so that you can do your everyday things, right? And so that in 30 years from now, you can play t-ball with your kid. It tends to be that when you're in the 50s-ish and someone says, all I want to be able to do is go for walks and, go do straight line activities, I don't care if I ever ski again, that's the person that you don't necessarily have to operate on their ACL. But we do know that the ACL is required in order to maintain stability for a lot of your everyday change of direction type activities. And so you reconstruct the ACL to try to limit the recurrent damage to the cartilage and the recurrent instability episodes. Once you do that ACL reconstruction, the hope is that you've tamped down on the incident and that they're not going to be plagued by problems. Are there risks for graft re-rupture and needing ACL revision? Absolutely, particularly in females versus males. I think we'll get into that a little bit later. But with a ACL that's reconstructed well, you hope that you can go back to all the things that you like, and that maybe you have a little bit more of an increased risk of arthritis in that knee compared to your contralateral, but that it won't limit what you choose to do.
Good. So say the ACL is torn and we have to do a reconstruction. Okay, so I'm going to poll all the people in our panel. So what are your choices for reconstruction and grafts? So let's start with you, Dr. Hopkins.
Well, it's patient specific. We've, first of all, in this population, we're absolutely not talking about any allograft, no tissue from cadavers. We're talking autograft or, the patient's own tissue. You can take it from a couple different places. I'm actually becoming a fan of the quad tendon. I do think that it is a very reproducible graft. It's a little bit more robust and a little less fidgety than the hamstring. And if I'm operating on a kid with open growth plates, especially, then I'm not going to touch the tibial physis, which I would need for that bone tendon bone. The bone patella bone is the graft that we often talk about or hear about in NFL athletes and all that. But in terms of kids, you want to respect the physis when necessary and use soft tissue. And so it's quad or hamstring in that situation.
Good. And then what about Dr. Patterson?
I'm going to second Dr. Hopkins, also becoming I would say, convert like a lot of orthopedic, out there to the quad tendon. It was, as I described to patients, it was the gold standard graft when we first started doing ACL reconstructions. And then it sort of fell out of favor based on not necessarily, I guess, availability, but ease of use when our technology advanced to make other grafts, maybe more reproducible. And now it's coming back into favor, and some really encouraging studies about some lower re-rupture rates and in certain populations. And like she said, it's reproducible. It's a little less dependent on the size of the patient in the sense of, having smaller hamstring tendons in some people. So I can always get exactly this robustness or size of a graft that I think is best for the patient. And then, and there's definitely some patients in which I still recommend or use the patellar tendon graft or the bone patellar tendon. Same thing. They're just, one is more words to the name than the other. There are some sort of known risks of that one, or I guess known, not necessarily side effects, but things that people experience with that. And so if someone is in a certain job or does a certain sport where they have to do a lot of kneeling, maybe don't recommend that one. Or again, an age limitation, sort of as Dr. Wallach mentioned it earlier, based on the physis and crossing, that we found, the soft tissue grafts, so the quad or the hamstring, might be better in someone even whose growth plates are just nearly closed or just maybe a little open. They have less trauma to the growth plate than putting the piece of bone that comes with the patellar tendon. So I'm doing more and more quad, and it's my new favorite and go-to for that.
And then what about you, Dr. Wallach?
So it's a function of age, and it's also a function of activities. First, I'll talk about activities. So if you're a wrestler, somewhere you're going to be on your knees. Wrestlers spend a lot of time on their knees and all fours. There's a little bit more knee pain for the first year to 2 years with any technique that uses harvesting from the patella, whether it's from the quad or from going down to the tibial tubercle. So we have to have a candid discussion about that. And for those, actually, hamstrings, I favor for that. In some of the cutting, twisting sports that don't have the knee contact, BTB, which is bone, tendon, bone, or quad, is actually an excellent choice. I also completely agree. Allograft is not something that I've used for actually several years now. It certainly has a place for the 35 and older patient, which I should say is not my population to take care of, but for the older patient who has less demands, just because the tendon itself is just not as robust. As far as the young child, it really depends. In the juvenile, the 10s and unders, things like the iliotibial band, which is a totally different structure on the side of the knee. One can do a reconstruction which approximates normal anatomy, which is very respectful of the growth plates. There are some other techniques using hamstrings, which I also use in this age group, which can simulate the normal anatomy, but still respects the growth plate. And then if they are a little later in adolescence, say 14, 13, depending whether male or female, there are times where actually I will go through the growth plate with a soft tissue graft like a hamstring, because the risks for them are actually much lower for growth arrest. So it really depends upon what they're doing as far as their sport and age.
I would agree with that. I mean, I choose my graft options based on the age of the patient. So I would say that the youngest age of ACL that I've done was a 7-year-old. And for that, the growth plates are wide open. So you really don't want to do anything to damage them. So for the really young kids, I choose ITB reconstructions, where there's really no risk of a growth plate injury. As you get, a little bit older and early adolescence, I'm a fan of hamstring reconstructions. But then I think once the growth plates are more mature and closed, I actually prefer BTB reconstructions. But I think I can get a nice solid reconstruction and get the knee nice and tight. So I think that was a great discussion for everyone. So we have another question here. So let's talk about some rehab. So Dr. Patterson, do you want to talk about some options for rehab, and how long do you typically send kids for physical therapy? And do you even have to do rehab?
Well, I think, either before surgery or after surgery, or in the rare, I guess, or, other slightly more unique situation where you might be choosing no surgery, which I see somewhat in my even older than 35, patient population, but certainly not something I would necessarily recommend in, the more pediatric or teenage population. Rehab can be very helpful in the acute phase after an injury. As Dr. Hopkins mentioned, when an ACL is first injured, particularly in a teenage, athlete or a patient, it gets very swollen very quickly. It's actually one of the, the harbinger signs that we ask a patient whether they come in, did your knee get very swollen within an hour? Because it tells us, even before the MRI, it can tell us what our concern should be or might need to be. And physical therapy, as we sometimes coin it, ACL prehab, you might see that in some of the literature online, can be really helpful to help, patients with some of their pain, because it can be very painful. If they have the bone bruising, it can be painful to walk on it, though it is safe to start walking on your ACL in most situations. And and then, help control the swelling and get some of the swelling down. One thing that happens to a knee, whether it's an ACL injury or any sort of injury, when there's a large amount of swelling in the knee, the muscle on the front of the knee, which is the quadriceps muscle, sort of goes to sleep and kind of shuts down. And that's one reason that the knee can start to feel even more unstable than just without an ACL. And, some physical therapy, either some, whether that's, some modalities that you can do at home or some modalities that they can really do specialized in a physical therapy office, various stim machines or other techniques can really help wake up that quad muscle again and get it to start functioning. That's also helpful post-operatively. And then, sometimes when knees are very swollen, getting all of the range of motion back can also be difficult for someone on their own because it hurts. And, particularly a teenager or someone younger, it's quite difficult. I mean, I'm not sure even I could do it myself without additional assistance to try and, really get that acute phase calmed down. And then, the old school wisdom is a lot of times we try to get some of the swelling down and the range of motion back and some of the strength back in the leg before even doing a surgery if we're going to go that route, because there are some out there that, there were some patients who had issues getting the range of motion back and developing a complication that we call arthrofibrosis, which is scar tissue in the knee, when the knee was too swollen and inflamed immediately post-injury when you rushed off to an ACL surgery. And so now, in professional sports, you might see some athletes going into surgery right away when they've torn their ACL, and definitely for good reason. You also see, there's a lot, if they're going to miss a season anyway, they wait, they do the muscle activation, and then get the swelling down and other techniques before even considering surgery for that. And then for the non-operative sort of route, probably an older population or a more sedentary, not just necessarily the high schooler who doesn't want to do sports anymore, as Dr. Hopkins referred to. Once the swelling is down and your range of motion is sort of more restored, we really focus on hamstring strength, quadriceps strength, and equalizing those so that there's not imbalance around the knee, core and hip, stabilizer strength, so that your, gait is completely normal and you're not favoring it any way or causing any further instability events, and other, activities like that to try and restore people to, again, more the old adult patient to some of their daily life functions. And then as for how long, well, I think I'll defer a little bit to Dr. Wallach and maybe Dr. Barsi yourself, who do a lot more of the kids. I would say it comes down to a little bit of what Dr. Wallach mentioned or referred to earlier, which is a little bit of what type of injury is it? Is it a full ACL tear? How easy is it for them to do therapy? Do they do well in therapy, or do they move slowly because the swelling takes a long time? Or again, sort of impulse control and other things like that might lead them to need to be in some therapy longer. I say usually minimum, it's going to be a couple weeks, probably just in a lot of, younger patients before considering surgery, unless there's other factors. And, probably quite a bit longer if there's a person who's going to choose, an adult patient who's going to choose more of a non-operative path.
Good. So we have another question here. Eric is joining us all the way from Richmond, Virginia. So he's asking us, why do we see so many ACL injuries in young teenage girls? So do you want to take this one, Kristin?
Sure. This question is something that I find particularly interesting, just about the gender differences in ACL injury in particular. I think this is something that's gaining a lot of momentum in the research. It's leading to offshoots of even practices such as Stony Brook now. Actually, we just established a women's sports medicine group meant to address the differences that do exist in gender. So in terms of ACL injury, females can be anywhere between 2 and 8 times more likely to tear their ACL compared to their male counterparts, depending on which paper you read. But also interesting is that they are 34% at a higher risk of contralateral injury or need for revision surgery. So it's like that second hit that can be really, really just a blow to the athlete. But the bottom line is, in answering this question, that there's not one answer. It appears to be multifactorial. So the 3 kind of arms of this of this answer are anatomy, neuromuscular control, and then hormonal or endocrine elements. In terms of our anatomy, females, the cross section of our ACL is actually smaller than males. We also have more classically a smaller and more narrow notch in the femur or in the thigh bone where the ACL sits. So there's less space there. And then we also have something called a Q angle that's greater in females than it is in males. And that has to do with the fact that how I describe it to my female patients is, our pelvis needs to accommodate being able to grow a child, birth a child, but then our knees still need to be over our ankles. So that hip to knee angle puts more stress on our knee. And as Dr. Patterson discussed early on, even at the start of our talk, valgus is an enemy to the ACL. And just in general, females show more propensity to land in valgus, have more valgus alignment just anatomically. And that kind of lends itself to that neuromuscular piece of the puzzle where we are more quad dominant than hamstring. So our quads are stronger than our hamstrings classically, where males are much more balanced. Being quad dominant puts more stress on the ACL because it draws our shin bone forward. Again, not an ACL friendly position. And we tend to land in positions with less knee flexion, less hip flexion, and more valgus. Our knees tend to cave in. This has been kind of delved into now in terms of all these ACL prevention programs, which Stony Brook has a great one. But if you watch a female jump off a box and land versus how a male jumps off a box and lands, we tend to do the knees in, the valgus position, which puts the ACL in a vulnerable state. The last piece is that hormonal or endocrine piece. And I think this is something that's been swirling around in the research for a long time. And we want to be able to show some sort of connection between phase of the menstrual cycle, phase of different hormone levels, and propensity to tear your ACL. And it has been shown that estrogen increases laxity, which increases the laxity of the ACL and does put it at risk for tear versus progesterone, which is shown to be protective. This is not something that anyone's really building into their practice yet in terms of starting a young athlete on an OCP or something like that. We're still not quite there yet, but there is something to be said for the phasic nature of female hormones and predisposition to ACL injury.
Good. And we have another question from Carrie along the same lines. So is there a longer time frame for ACL surgery to return to sport in female athletes? And then Dr. Hopkins, do you want to address this as well?
I don't think so. I don't find that my females are any slower to return to sport than males. I do think, in building on what Dr. Patterson was saying before about the rehab, before I operate on anyone, reconstruct their ACL, I make sure that they understand that this is a partnership that, we are going to be seeing and talking a lot to each other for a solid year, that this is an all-in process that takes time, and you're going to feel good before I'm going to let you go back and play. So there's a frustration element, and then there's a psychological element too. When I finally say you can go back and play, how do you feel about cutting and pivoting on that knee? Do you feel like it's ready? There's a real psychological component to ACL injury and recovery. But to answer your question, I don't actually think that I've seen females take longer to get back to sport.
Good. And now a question I'm sure many of our viewers have, sort of the $1 million question for tonight, is how long can I return to play? How long is it going to take to keep me out? So I'm going to give this one to you, David.
Great. So there's a couple of issues at work. And even before the return to play, there is a period of time when the graft is actually at its weakest. And there's a little difference between bone, tendon, bone, and hamstrings. But during the 6 weeks to 12-week period, often when there's revascularization of the graft, it's a little weaker. And sometimes, because some patients feel so good, they kind of don't listen to protocol. They may stop wearing their brace. They may start getting a little too active. And that's actually the danger zone because they feel too good. And this is actually something that I tell them long before the surgery. You may feel too good, but you still need to listen to what we say. The other issue is, and we've discovered this over the last several years, is that Children, when they go back, if they go back too early, do have a higher rate of re-tear, a failure of the graft. And this is a function of a couple of things. One, if you remember from your own life, you were probably a lot more athletic and active as a 17, 18-year-old than you are as a 30-something-year-old. And so the level of activity is much, much higher with the child. So they need more time to get their muscles, their hamstrings, their quads stronger. They need to learn proprioception. They need to learn how to appropriately do cutting activities. So in the past, where we said going back at 6 months is great, we really revised that. And now more than 9 to 12 months is the safer amount. And I will tell you, it's actually hard to slow someone down for that period of time. But when you listen to those instructions, the risks of re-tear go way down.
I would agree with that. I would say that right now, my current protocol is inline type of activities, probably around somewhere between 3 to 6 months, and then back to full sports, usually around 9 months. And then now I'm using what's called a functional ACL test to determine when it's an appropriate time period to go back. Because we know not only is the timing is important, but the patient has to be ready. So it's really looking at strength and motion of the knee. So I guide that to determine my return to play. We have another question here from Dawn. So Dawn wants to know, how can ACL injuries be prevented? So Diane, I'm going to give this one to you.
That's a really excellent question, and something where our research is continually evolving. There's a couple arms to this sort of answer. One is there's a couple validated ACL prevention programs. There's many others that are out there, but there are a couple that research has shown to reduce the risk of some ACL injuries. They all tend to focus, they tend to be something, and as Dr. Hopkins mentioned, we do, have an excellent one here at Stony Brook. That all of our sort of female and all athletes participate in when they're in undergraduate sports. And then most of the focus of the programs that have been shown to be successful, a lot of them are also, originally from maybe some European countries where they have a lot of more what we would say is registry data and large numbers of patients to study. But they're, usually at least about 6 weeks. They're intensive, training to focus on a couple things. One is, the quadriceps and the hamstring ratio, because, women, as Dr. Hopkins mentioned, might have a higher rate of ACL tears because inherently are more quadriceps dominant. And so therefore they have the focusing on flexibility and strengthening so that it's more even, which leads me to also focusing on, as you would say, landing mechanics. As Dr. Hopkins mentioned, female athletes tend to land with more knee valgus, which puts more stress. And so, focusing on landing and reteaching neuromuscular control so that one, lands from either a jump or even just a stride, depending on what their sport is, with more hip stability and core stability, as well as less knee valgus and other strengthening modalities like that. And then, they are usually more of a hands-on. They're usually definitely more supervised sessions. Those have all been shown to be the more successful programs for ACL prevention. I know, and then a couple other things that can be done or to think of would be, Dr. Wallach mentioned, and we all have sort of mentioned neuromuscular control. One thing that can affect neuromuscular control is fatigue. And so one thing to sort of mention is a lot of our pediatric athletes these days of even a very young age are playing multiple sports teams, either school and club all at the same time, and they might even have practices on the same day. And so it is difficult to potentially try and get a young athlete like that to make some time for what seems like a boring strengthening program or into physical therapy when they start having some sort of feeling of weakness or symptoms that is maybe a precursor to an injury. And then, if someone's in their second practice of the day or their fourth game of a tournament and they haven't had the proper fitness for it, they might be at an increased risk due to the fatigue that affects their ability and for their muscles to function normally, and then lead them to have a higher rate of some injury. So that's something that, we talk a lot about when it comes to chronic injuries, but it is also something that I think is relevant when it comes to more of an acute injury. A couple things that I think have not really been shown are sort of preventive bracing, or things that sometimes I get asked about that, historically has been something, but it hasn't, I don't think, really been shown to be a necessity, preventively bracing kids in their in sports. We see a lot of football players wearing them because I think it helps everyone feel better, but there's only some types of injuries that prevents, and unfortunately one of those isn't ACLs, because sometimes, despite our best preventative efforts, sometimes things just will continue to happen.
Good. And then we have another question from Carrie. So she wants to know if there's any research regarding females less likely to return to play at the same level that they were participating prior to the injury. So I'll take this one. So as far as I know, there's really no research showing that there's any difference between females and males returning to play following ACL reconstruction. The goal of the surgery is really to provide stability to the knee. So if we provide that stability with surgery, I think there's a really good chance of you returning to your level of play. We have another question here. So often the case that the meniscus is torn along with an ACL. So how might that differ in terms of recovery and surgery? So do you want to take this one, Kristin?
So that's a great question, and unfortunately, it's more common than we would like it to be. Particularly with an acute ACL tear, a lot of times we see that the medial meniscus will also become torn, and that has to do with that rotational event that happens, and the meniscus kind of gets trapped between that thigh and shin bone and takes a hit. So, when the research has shown that the best chance for meniscal tear healing is when it's repaired in the same setting as an ACL reconstruction. I think the theory behind this is that, we're drilling into the femur and the tibia in order to place our graft, and we're creating, blood products and bleeding into the joint, which promotes healing of the meniscal tissue, which is usually fairly avascular. When you're dealing with adult population, when they have a meniscal tear, we're not talking to them about meniscal repair. We're talking about meniscal debridement, which I explain as like trimming a hangnail. But with kids, you always want to give the meniscus a chance to heal. And when the meniscus gets torn with the ACL, we will try to fix that meniscus. We'll repair that meniscus, and at the same time as reconstructing the ACL. It is important to explain to the patient and to the family that when they also have a meniscal injury that's going to require repair, it is going to change your post-operative protocol. Where Diana mentioned, usually right after an ACL reconstruction, you're in a big brace when you wake up and you'll leave with crutches, but you're allowed to put weight on that leg. And we're immediately encouraging you to wake up that quad and start with your range of motion. Depending on what kind of meniscus tear you had and how big the repair is, we may be slowing you down. That may mean that you're not allowed to put your full weight on it. It may mean you can't bend past 90, even if you recover your motion really quickly, you're going to have that limitation. And that's to limit the stress across that meniscal repair. But it is a great question. And unfortunately, the two injuries do happen together fairly often. Good.
So another question that I often get asked is, why should I come to Stony Brook for my ACL? And I'll take this one. So I think Stony Brook Children's is really Suffolk County's only academic children's hospital, and that offers several advantages. So first and foremost, we have a very active research program. So what that means is that we can offer you the latest and most cutting-edge technologies available. Second, we have a stellar team of surgeons, physician assistants, physical therapy, and athletic trainers who work really well together to try to optimize your care. And then finally, as many of you have mentioned tonight, we have a great ACL prevention program. Because while we all like to fix the ACL, the best outcome is not getting hurt in the first place. So I'm going to check to see if we have any more questions left in the queue. And I think we're good. So I'm going to wrap things up. I really want to thank all of our panelists today for their insights on ACL injuries. I want to thank you, the viewers, for listening, for watching, and for asking your questions. I hope you learned a lot. On behalf of Stony Brook Orthopaedics and Stony Brook Children's, we're really ready to take the best ideas of medicine to take the best care of our patients. Thank you and good night.